welcome everybody. My name is Jay Godfrey. I am a co-founder of Nushama Wellness. For those of you who don't know, Nushama is a network of clinics in New York, Rockland County, which is about 55 minutes northwest of New York City, and Aventura, Florida. We were founded about almost 5 years ago by myself, Dr. Stephen Radowitz, who is on this webinar, as well as Richard Meloff. And we started out as a organization in part to help solve this mental health crisis. Depression was at crazy heights during COVID and still is a major crisis. Anxiety, PTSD, and OCD remain very, very difficult to treat. And Nushama's goal from the beginning was really about giving options that explore these mood disorders in a different way. And one of the ways that we've started treating people back in 2021 was through ketamine-assisted therapy. And ketamine, as you know, is a long-used anesthetic, but also an analgesic, and also a wonderful neuroplastic tool. And I want to introduce today a very, very exciting development that Nushama is bringing on AMPA One, which is a new form of TMS, which we're very, very excited by, because TMS is something that's actually been around for quite some time. And on our webinar today, we're going to discuss why Nushama is bringing this on now, but also some of the exciting research that the folks at AMPA have conducted to really change the game for TMS and for mental health. I'm going to start by introducing my co-founder, Dr. Stephen Radowitz. Dr. Radowitz is a Canadian like me, went to McGill University and Chicago Medical School, has been an internist and still is an internist, as well as ran alcohol and heroin detox centers, and is really just an incredible doctor, not because of his medical expertise, which is incredible, but also because he happens to be one of the most soulful doctors anybody has ever met. Stephen studied Kabbalah for about 25 years, and it really allows him to have a bedside manner that I think most Nushama patients would agree is second to none. I am also deeply honored to have Dr. Jonathan Downar, who's the co-founder of AMPA Health, on this webinar. He's a leading psychiatrist and neuroscientist at the University of Toronto. He's actually has 180 or over 180 peer-reviewed publications in major medical journals like The Lancet and Nature Medicine, and his work has been central to the advancing of TMS. He led the landmark 3D study showing that sessions could be reduced from about 38 minutes per session of TMS down to 3 minutes without sacrificing efficacy. Today, his focus is on translating neuroscience into scalable real-world treatments like innovations we're discussing here today, like the AMPA One. So I'm going to jump right into the questions, Dr. Downar and Dr. Radowitz. I'll start with Dr. Downar. Let's start from zero. There's a lot of people on this webinar and who will be seeing this maybe after on clips on Instagram. Starting from the ground floor, what's TMS? What's it actually doing to the brain? And how does it work?
Thanks so much for the warm introduction, Jay. I'm just checking the audio is coming through clearly. Great, fantastic. No, so that's a great starting question. So talking about transcranial magnetic stimulation, it's a 40-year-old technology invented in 1985 that is capable of stimulating and activating the brain cells or the neurons of the brain without requiring electrodes or surgery. The way it does that is by using powerful, focused magnetic field pulses that are about as strong as the field of an MRI scanner, but focused down into the size of maybe a quarter. And it's delivered through a little magnetic inductor that's placed over the head. And when you apply pulses through there, the pulses will activate the brain tissue just underneath the inductor. It's very powerful and very precise. When it was first developed, it was used to activate the motor cortex, which means that if you place it over the area of the brain that moves your thumb and you apply a few pulses, the person's thumb will move. Or if you place it over the area that moves the toes, it feels a little, if you experience it, it feels a little bit like when your knee is tapped with a reflex hammer, the body part just sort of moves. So that was the first discovery of it. But What was learned later is that if you do trains of pulses, then you're firing the neurons over and over again, and it acts a little bit like an exercise program. The brain has a really important property called neuroplasticity, which is its ability to rewire itself, normally through process of learning and memory. But with TMS, you're actually activating the powers of neuroplasticity to reset or rewire the connections. In every session of TMS, you'll get a few hundred pulses and it will strengthen the connections there. And if you do enough sessions, gradually the strengthening becomes powerful enough that you can actually use it as a treatment. Since 1995, people have been using it to treat depression. Since then, people have looked at a wide variety of there are about 2 or 3 dozen different neurological and psychiatric conditions, ranging from OCD and PTSD, bipolar disorder, depression, and so on, all the way to neurological conditions like Alzheimer's and Parkinson's that people have studied and published trials on. A small number of those studies have made it all the way to FDA approval, but in the scientific literature, there's a lot of different conditions that people are trying to treat. And if you know what target network of areas or circuits in the brain that are associated with a condition, you can often go there with a TMS coil, and without needing surgery or electrodes or anything like that, as an alternative to medications or as an adjunct to therapy, you can go in and deliver pulses and strengthen the activity of these regions.
Great. That was amazing. Thank you, Dr. Radowitz. You know, as one of the premier, and I'm biased, but as one of the premier providers and physicians in the kind of psychedelic ketamine space. You know, this must be very interesting to you and out of the box for you. But who is TMS for, in your professional opinion, and what type of patients would benefit from it most?
Right. Well, there's a lot of overlap, obviously, with our ketamine program. So the main indication, which we see, and TMS is FDA cleared for, is major depressive disorder, or often treatment-resistant disorder, treatment-resistant depression. And but you know, it's also, and same thing we've seen with ketamine. We've seen incredible results also with anxious forms of depression, OCD, and various forms of addiction. So there are many, you know, not some of the studies that we have FDA clearance for, you know, it goes beyond that. And we've seen that the same thing with ketamine. So people also who are not ready for, you know, our ketamine program, there's an experiential aspect to that, you know, there might be people who are not ready for such an experience. And TMS, and looking at the data, you know, the newer data, we're seeing almost equal efficacy with TMS. So it's a great another option, sort of a non-invasive, non-typically pharmacologic option for people who are looking for to either, you know, not go on medications, or maybe eventually you know, to wean off some of the medications, especially when there are significant side effects related to that. So, and you know, Dr. Downar also mentioned a while ago that some of the people who benefit most are some of the people with the most entrenched um, uh, issues, most entrenched, like PTSD or mood disorders that are a little bit more significant. And could you explain that, Dr. Downer? Because I found that extremely interesting. How you?
Yeah, so this is, I mean, I started treating people with TMS about 15 years ago and probably had about 5,000 people come through my office. And we were a free charity clinic associated with the University of Toronto. So we sort of took anybody who wanted to come and we'd try and think about what circuits were involved and we would do treatments for them. One of the things we were struck by is that when people would come for their depression and we treat them, they'd often tell us that other things were getting better too. So it was a little bit like a kind of early Ozempic moment where people were, you know, taking the medication for one thing and noticing it was helping with lots of other things too. So the second patient I ever treated, her bulimia went away for the first time in 20 years. So we thought about that, and then we had other patients who came in with OCD and their OCD cleared up or their PTSD cleared up. Even people with really, you know, supposedly tough conditions like borderline personality disorder, they would actually get better on TMS, which is a big surprise to all of us until we sat down and took a closer look at what TMS was doing. Um, as you mentioned, my original background before medical training was in neuroanatomy, functional neuroanatomy, and so we would bring people down, we would scan them and look at the brain circuitry that was being active on different tasks. Um, so let me see if I can explain what when people do TMS, what they often describe is very different from just antidepressant effects. What they describe, it's like having an enhancement of your coping capacity. People say that they're better able to regulate their emotions. that things that would normally be very upsetting for them become manageable, that they don't get overwhelmed. And even if they do get overwhelmed, that they're able to recover from it much more quickly. Now, some people have this naturally. Like we know that if you look at people in the world, there's some people who've been through horrible trauma in childhood and through their lives, and somehow they never go on to develop an Axis 1 mental health disorder. There have been studies where they've scanned people like this to look at whether their gray matter is any different. And people who are lucky enough to be able to survive trauma and be resilient to it and cope with it, they happen to have extra gray matter, just a little bit of extra gray matter that's detectable in certain areas. And when we looked at where those areas were, it turns out that they line up very nicely with the areas we've been treating with TMS for all these years. So a treatment that was developed because they noticed that depression was improving on it, it actually now looks like we were actually stimulating a more broad-based circuit that allows you just in general to cope with stuff. And so probably for that reason, when a person does a course of TMS, it's rare that they just notice improvements in depression. If you get the circuits right, they can improve and they can notice improvements across a wide variety of things.
That's amazing. It's amazing. As somebody who's on the business side of a mental health clinic, to hear such innovation and hear such extraordinary results, it's so exciting for us. Dr. Radowitz, a question for you as a clinician who, again, has treated a lot of people with ketamine. I think you've done something like 15,000 ketamine treatments. And you've heard of TMS. It's not new.
Yeah. No.
What's interesting about TMS now? Why did Nushama add it? What were the roadblocks for clinics like Nushama prior to AMPA from adding TMS?
Mm-hmm. Yeah, I mean, I think we looked into it a little while ago, actually, maybe a year and a half ago. And some of it is just sort of logistics, having this huge, big machine, the costs of the machine in our unit, and also the protocols that were initially presented to us, these 36, these 20 to 36 day TMS protocols were just not, just doesn't work for busy New York people. It didn't make sense to us. And also the way the training AMPA system, which it's much easier to actually implement in our system. It's smaller. You can actually move it from room to room. It's portable, and the protocols associated with it that have been presented to us, especially with decycloserine augmentation, the numbers are just pretty impressive from what we see. So to do all that in one day really fits in with what we do at Nushama and our clientele, the people who are looking for it. So I think it's an exciting thing, and also something to layer onto our ketamine program as well, so to integrate, especially with a one day, we could sort of mix it in. And there is a lot of research, and we'll talk a little bit about that afterwards, but there is quite a bit of research using ketamine and ketamine protocols in conjunction with, not at the same time necessarily, but in conjunction with layering it in with TMS, and especially one-day TMS, or dividing that up. So
yeah, it's when we were bringing Spravato on, which is the intranasal ketamine that's FDA approved, we went to other clinics, and I would ask as a entrepreneur, like, how's your TMS program? This, of course, was before AMPA came on the scene, and they said, well, it's not that successful because people have to come for 36 days in a row, and there's a super high attrition rate. So, with that in mind, I think it makes total sense why Nushama is doing it now. Dr. Downar, tell us a bit about the actual device itself. What makes this piece of equipment, aside from its portability, special? And how does it compare to everything else other than it being a lot more portable and smaller?
Sure. Well, so your question comes to a really important distinction. Is there are two things going on. The recent innovation has two parts to it. One part is that, is the one-day treatment. So as you mentioned, TMS used to be 36 sessions over 36 days. And then, beginning in 2010, people moved to accelerated protocols. The first one to reach FDA approval was the same protocol, which is 5 10-hour days, so quite long, but 5 long days, but still proof of concept that you can get excellent remission rates. That also involved an MRI to personalize the location. And then the one-day treatment, it was the idea of not doing it over 5 days, but just doing it all in a single day. And the way you make that work is, as you said, by giving a medication ahead of time, which enhances the brain's plasticity. So we can get to that in more detail, but just the reason we've managed to keep on improving things is we made the sessions shorter, and then we did more of them per day, and then we started adding on the neuroplasticity enhancement. And once you do that, quite a lot of people will get all the way better in a single day. They don't even need 2 or 3 or 5 days of treatment. They will do well on just one. So that's great because it means a lot more people can find a day than can find 36 days or more days or whatever. So that's very helpful, especially if you're flying in or coming from some faraway place. Um, the other thing, the long-term mission of the research program I had going at the University of Toronto, and then AMPA's mission as a company, was to make TMS more accessible. So something that would be available in more places. When I started doing TMS at the University of Toronto, setting up a TMS room was it was more than just a treatment chair. You had to fill it with about $250,000 worth of equipment, and you'd spend 4 or 5 weeks training a technician. And if somebody left, you'd have to find someone new, and then they'd have to train for weeks to get the hang of it. And it's just very finicky and fiddly. We decided to try and work on how to improve this. So one key part of this was miniaturizing it. You mentioned it's portable. So the idea is to build the whole device down into a suitcase-sized portable unit that could be taken around and moved from place to place. You could take this. We designed it so it could eventually go into people's homes. We're not doing that at this point, but it was designed with that capability in mind. And so the hardware became small and simple. The second part we did was one of the key parts to do TMS properly is to make sure it's on the proper place on the head. And there you can see people wear a little cap. Traditionally, the caps are blank, and practitioners have to learn how to draw the caps, and people make a lot of mistakes drawing them. Even experienced people will sometimes not draw them properly. So one of AMPA's innovations was to make pre-printed caps. If you look on my screen here, you see me holding one here in a few sizes, so that all the places where you might need to stimulate are already pre-marked on there. And then if you see the coil is small and lightweight, but it also has one extra feature to it. I'm going to hold it up to the screen so you can see at the bottom of this coil, there's a little tiny camera. It's that's only 4 millimeters wide, and it is placed right in the middle of the coil so that you can see what you're doing. And this allows an outside practitioner to be 100% sure that the coil is being placed exactly where it's supposed to be over the little mark. It also means that if you're a technician and you're training up, it actually doesn't take 4 weeks of training to get the hang of it. Typically, the training sessions are about 4 hours, and then people have proficiency. And the newest versions of the software actually use AI to sort of make it as a safety mechanism to make sure that you can only deliver the pattern of stimulation if you're in the right place, and if you happen to slip off, then it won't. So if you're a provider, it provides a lot of assurance that even if you had 20 machines out there, you can keep an eye on all of them. You can be assured it's being done properly. And if you're a patient, it also provides reassurance that yes, you are indeed getting the proper protocol over the proper part of your head, and so that's very helpful.
So Dr. Radowitz, after demoing this machine and getting trained on it, and I think you touched on this, but you've treated a lot of New Yorkers, and now you're treating a lot of people in Miami. But why is this appealing to New Yorkers? Is it?
Yeah, I mean, taking 36 days off of work is just not. It's just not. It just doesn't work. It's hard to get them to take off 6 days of work for our ketamine protocol. Sometimes we write letters, but it would be, and it also raises, there's also privacy issues, people leaving work and it's not just, the 2 hour, it's probably at least a 2 hour, situation for them, every day for 3 days. So that can be an issue with most people. So that, definitely that alone, I think doing a 1-day protocol, maybe even on a weekend, is an incredible, option for most people. And so I think that alone, that one thing alone, absolutely. And then how it integrates with some of the other treatments that we offer, is another.
And Dr. Downer, if you could kind of dive into kind of what does the research say about accelerated TMS, and what areas of the brain are we targeting, and why? Like how does the stimulation into different areas of the brain actually affect or improve certain mental health conditions?
Sure. So that's a great idea. So let's talk first about accelerated TMS regimens. I mean, traditionally, when TMS was first developed as a therapy. The initial practitioners who did it, folks like Mark George and Alvaro Pasqualeone, they would bring people in Monday to Friday once a day, and so it was about 24 hours between sessions. And these were mostly outpatients, so they didn't come in 7 days a week. It was just on weekends. So traditionally, and that was just the way, and the TMS trials were done for a very long time. Because you do it once a day. Sessions are 24 hours apart. And it was only starting in 2010 that people started to look at doing more than one session a day. So people started looking at, could you do 2 or 3 or more sessions a day? In 2010, there were 10 sessions a day being delivered. And it gradually became clear that you didn't need to wait 24 hours between sessions, that 60 minutes was fine, and in packs, even 24 minutes would be enough time between sessions, which means you can get a lot more sessions done per day. That's very helpful because we now believe that your progress in TMS is just, you do need to do about 30 or 40 sessions. That seems to be what most people need. But unlike with medications where you can only take so many per day, you can actually turbo run those sessions. And unlike going to the gym, it would be a little bit like a situation where you literally could go to the gym 10 times in a day and be 10 times as fast at it. So for whatever reason, TMS seems to be like that. You need X number of sessions in the mental gym of TMS, but you can do those sessions half an hour apart. And so the accelerated regimens are all about improving patient convenience by condensing those sessions down into fewer visits. And the newest breakthrough in that is that you may not even need 30 or 40 sessions if you enhance the brain's neuroplasticity with a medication first. You mentioned the medication D-cycloserine, which we can talk more about later. It's called a neuroplasticity enhancer or neuroplastogen. It works on a receptor in the brain called the NMDA receptor, which happens to be very similar to the receptor that ketamine works on, except that ketamine, at least initially, blocks that receptor, whereas D-cycloserine does the opposite. Instead of blocking the receptor, it actually stimulates it a bit. That receptor is key for the neuroplasticity of TMS. So by itself, D-cycloserine doesn't seem to do.
Yeah, we need to go.
Oh, sorry, I can hear. By itself, D-cycloserine doesn't do it. By itself, D-cycloserine doesn't do. I mean, it works as a weak antidepressant if you give it over weeks and weeks. But if you combine D-cycloserine with the brain stimulation, it makes TMS do 3 things. First of all, you need only about half as many sessions. Second of all, the remission rates seem to double. And thirdly, the durability also seems to go up by a factor of 2 based on what we've seen so far. So, and the best part is it's not even a particularly expensive medication. It's got a safety record established over decades. You can get it from a compounding pharmacy. It's almost a freebie. It's a very clean medication. It's been around for a long time. So adding on D-cycloserine to accelerating is what's allowed us to accelerate things. Part 2 you asked was about brain networks and so on. I can address that, but that's a whole other monologue. So maybe I'll take a pause and we'll get to that in a second.
Yeah, that sounds good. I recognize, maybe for the lay person, if there's just a quick overview that you can do on, for depression, we target this area of the brain. Mm-hmm. For OCD, we target that area of the brain. And for, anxiety or PTSD, I think for people learning about AMPA and TMS, just kind of a general broad stroke would be super helpful. And by the way, I am seeing everybody's questions in the chat. Continue to place them. I will slot them in the right moment.
Sounds great. So one thing I should clarify, when you're doing TMS, you place the coil over a specific spot on the brain, but actually when you deliver the pulses, they're powerful enough that they travel to all the other areas of the brain that are connected to it. So TMS doesn't activate a region, it activates a network. What we've learned in the last 5 years, there's been a really, really important body of work coming mostly out of a lab at Harvard, but a few other places by Sean Siddiqui and Mike Fox and others, where they were able to, for the first time, really map out which networks were associated with depression and anxiety and PTSD and OCD. It's an interesting method. You have to go to the literature and find people who've had brain injuries, focal brain injuries, and there are databases of veterans who've had, wounds in combat or people who've had strokes that took out a little chunk of the brain. And so there's no one OCD area of the brain or depression area of the brain or anxiety, but there are networks. So if you look at people who, let's say they develop depression after a brain injury, they don't all have an injury in exactly the same place, but if you look at where the injuries land, they all tend to land on a specific network in the brain. And same for OCD. There's an OCD network, and there's an Alzheimer's network, and there's a psychosis network, and there's for many different conditions. And PTSD, what's interesting is there's also an anti-network as well. So there are cases of people, I've seen them, who've had OCD their whole lives, and then they get a tiny stroke that damages one area of the brain and their OCD goes away instead of arrive. Also seen patients who develop OCD after injury to a certain brain area. There are some brain areas where people get a small stroke there and actually their depression goes away and it clears up. So using these mapping techniques, we've arrived at these networks of areas that are associated with depression, anxiety, and OCD, and so on. And now what we're seeing is that those networks have been translated into specific spots on the head that we can place coils. So we are starting to be able to target them. The most interesting of all of these is to notice that there are even some networks which seem to be involved across most disorders. In other words, if you look at all these different networks, they all have some points of difference, but they also have some overlaps. So the most fascinating part is to look at, okay, are there any parts in the brain where all of the different psychiatric disorders overlap? And it turns out there are. There are some areas in the brain that are common to almost all of them. So just very recently, in the last few months and couple of years, people are starting to target what they call transdiagnostic regions. As I mentioned before, those regions tend to be involved in things like emotion regulation. So, one thing that happens that's very common is regardless of whether you have depression, anxiety, bipolar disorder, addiction, you often find that there's a loss of control. You may lose control of your thoughts or your behaviors or emotions. And if you could somehow get your control back, then you'd be able to, snap out of it. So the interesting part would be using a TMS coil to go to these areas and strengthen them transdiagnostically. And as I mentioned at the beginning, it looks like some of the main areas that we target with TMS land on this transdiagnostic network. So if you look closely, you're not just treating a person's depression, but the other conditions that they have alongside the depression. It's almost like they're not separate diseases or separate disorders. They're just different manifestations of a common underlying loss of cognitive control. And TMS differs from medications and probably from psychedelics. TMS is probably the one kind of technique that allows you to restore the person's cognitive control. That's a bit unique.
That's very, very interesting. And I'm going to take one of the questions from the chat, but tell me about the fact that this new technology AMPA that you've helped develop is 1 day. The same machine, it's our understanding you can do the standard treatment protocol. And one of the cool things about your 1 day treatment is it's really 20 treatments times 3 minutes, meaning you have the stimulation for 3 minutes, you take a 27 or so minute break, then you have treatment number 2, 27-minute break, and so on and so forth. If someone were to do standard TMS over a 36-day period, is each treatment for depression 3 minutes?
So yeah, under the standard FDA clearance, when TMS was first FDA cleared back in 2008, the protocol that first made it above the bar was a 38-minute protocol. It's the one that we used in my clinic in Toronto back in 2010 when we got going, and very quickly our charity clinic of free TMS filled up very quickly because more and more people showed up, and if the treatments take 38 minutes, it doesn't take that long before your clinic is full. So we started looking for ways to do that, and it was a Canadian team of Dan Bloomberger, Fidel Villa-Rodriguez, Jeff Daskalakis, and I who published the 3D study. And that was where we found a way to repattern what we used a way that others had discovered of repatterning the pulses so that you did them all in 3 minutes by mimicking the brain's natural rhythms for plasticity, a thing called theta burst stimulation. And these theta burst stimulation protocols only took 3 minutes. The question was, how do they work compared to the regular 38-minute treatments? And so we spent 5 years doing a giant 400-person study, and we eventually got it published in Lancet, and both groups did equally well. So, which we were surprised at, because you think that if you're sitting for a chair in 38 minutes with like a nice technician who's being warm and friendly and chatting with you for 38 minutes, that's better than 3 minutes of sitting there getting. So, but the 3-minute people actually did just as well as the 38-minute people, and so that made the sessions faster. That unlocked the ability, as you mentioned, to do multiple sessions per day. The next thing patients ask you after you've got a 3-minute treatment is, well, I drove 2 hours to get here, so can I have more than one? And the answer is, as long as you keep them enough minutes apart, then you actually can do more than one a day.
That's great. And in terms of adolescents, we have a friend of the company who's on the chat who asked, is this treatment available for adolescents? And what can you tell us about that?
So I'll talk about TMS in general. In the research world, TMS, there are case studies and case series that go all the way down to age 12. And I personally have performed treatment in exceptional cases on people a little younger than 12, typically for things like OCD and so on. So you will see it used in adolescents off-label. The FDA has begun to clear various manufacturers' TMS devices down to age 15. So age 15 is on label. I'd say it's not uncommon in New York and other cities if you walk into TMS clinics to see treatments going on for 12 and under on an off-label basis. The AMPA device is currently cleared in adults. Adolescents are coming, so treatment will be off-label if you're in adolescents because it is sort of device specific. But I am personally aware of clinics that have had those discussions with patients and decided, as you say, for an adolescent, it can be tricky to come in for 36 days. If the family have to come as well, it's much easier to try and book them to come in on a Saturday. So, if that turns out to be safe, it may just be the only way the person can come in is if it can be done in a day. So I've seen clinics do that, and I will say I've seen good outcomes with it.
Yeah, and look, as a parent myself, and I know there's probably a lot of parents on the on this webinar. You want to do anything for your children, and OCD specifically is such a hard indication to treat. And I don't know a parent that is struggling with a child with OCD that wouldn't want to give it a shot on the one-day protocol. Dr. Radowitz, from your perspective, who should not do this? What type of patients wouldn't be ideal? And, what are the risks in your opinion?
Yeah, I mean, there are few risks to TMS. Some people with uncontrolled seizure disorders are high risk for seizures. We would avoid that. There is a small, I think it's 1 in 10,000 risk of TMS inducing a seizure in those who are predisposed. It's a very low risk, but still it might be something we would, maybe look into or avoid, or if, get clearance for that. Any type of metal within about 30, I think it's about 30 centimeters of the coil, cochlear implants, pacemakers, skull, like any type of metal that is a magnet, it induces a thing. So that would be a contraindication. You were listed here less than 4 hours of sleep. Obviously, that would be, the night before, we would encourage people to get a little more sleep than 4 hours. It can decrease the efficacy and we encourage people to get a little bit more than 4 hours of sleep before. And then, alcohol, anyone who has an active alcohol or drug addiction, which could raise the seizure risk possibly with any type of withdrawal, high benzo use, benzodiazepine, and maybe withdrawing from benzos would be an issue. Benzodiazepines would be an issue. So those are the main issues. But overall, it's an incredibly safe treatment, and there are very few, other than that, a few contraindications. Maybe Dr. Downer, you have any others you can think of?
Yeah, so one of the nice things about TMS is there are relatively few contraindications. I mean, we get a little bit worried when people have electronics around their skull area because that could be potentially damaged by the pulses. We get a little bit worried when people, we want to look carefully if people have metal shrapnel around the eye or that sort of thing, or if people have eye injuries or retinal detachment, you have to be careful. Seizures, again, typically, seizures are one of the relative contraindications for TMS. I will say regarding the risk of that I have personally treated 5,000 patients and overseen treatment in clinics that have done 12,000 patients worth. So I know clinics that are treating over 12,000 patients and haven't seen a seizure yet. I've seen one in my career, and the most sensitive area of the brain is actually the motor cortex that moves the hands. So the trick to avoiding seizures seems to be to stick to low frequency protocols and stay away from that brain area, which isn't really involved in depression treatment anyway. It's often when that area gets accidentally stimulated through poor technique or overly aggressive stimulation that a person's hand starts moving, and this can happen. And what's interesting is low frequency TMS, like at very low frequencies, can actually be used to treat seizures that are not responding to medication. So there's even trials where they've used TMS in epilepsy, but you have to use low frequency stimulation. So there are always, even for a person with a seizure history, there are ways to do TMS, and typically you would there are some low frequency protocols that work for depression and anxiety. So it's something to be approached with caution, but it's not impossible. It can be done with the practitioner and the patient have a good discussion about how to proceed.
That was one of the things as somebody who sat in the chair to get tested or to feel what a TMS treatment feels like. I was actually very, very surprised because I'm sure there's a lot of people asking, like, what does it feel like? And I was always told that it feels like a woodpecker tapping on your head. And to me, it even felt like less than that. And as a patient and as a person in the chair, to have a little agency is amazing. So there's such a collaborative relationship between the technician who's administering the treatment and the patient in terms of, turning the intensity up or down if it's too high or too low. And so that's something that, the patient isn't powerless in the experience. They're letting the technician know. And the way I look at it as a non-clinician is it can be slightly uncomfortable, but it is certainly not. I did not experience it to be painful myself. Dr. Downar, in the research for depression and TMS, we get this all the time with ketamine and with Spravato, which is also S-ketamine. How long does it take to feel results?
So this is one of the interesting distinctions between the way TMS works and the way that ketamine works. Ketamine and other psychedelics may act as a kind of a brain reset. So, circuits in the brain that are gotten stuck in feedback loops of the same thoughts or the same behaviors over and over again. Psychedelics might be a sort of a question of adding a bit of noise into the system so that everything sort of resets. And it's a very high level way of describing it. TMS is different. TMS is more like an exercise program. And so just as with an exercise program, the results don't often show up right away. Like I would love a world where you would go to the gym and you would instantly, be super buff and fit and so on. But in reality, usually it kind of takes a while for things to exert themselves. When you do the one-day treatment, at least in our published study, when we did the one-day treatment, we didn't really see anybody walk out the next day feeling, 100%. A week later, about 20% of people were in remission, but 2 weeks later, 40% were in remission. And then 3 weeks later, 50% of people were in remission, and then 60. And by the time you're 6 weeks out, you're a little over 70% remission. And we've now done this in over 200 patients, and we've tried all kinds of different variations and recipes. And one common element seems to be that you don't get better immediately, that possibly because the brain takes a while to rewire itself, just as you may pass exercise, but it can take up to 6 weeks to get the full effects. But once it's there, it seems to last quite well. So almost everybody's still doing well at 3 months. Most people are still doing well at 6 months, and we've now still followed some people out to a year or 2 years almost. And there are some people who last very long. I think what it'll turn out to be for one-day treatment is, I think it'll be for most people something you do maybe once or twice a year. And for a handful of people, it'll be something you might just want to do a touch up every 3 months.
Very good. And then Dr. Radowitz,
I just want to ask Dr. Downer, you mentioned, the precuneus, the 3 hertz precuneus protocol. Those the onset of action, the effects you said you see more significant effects earlier on with that
Yeah.
protocol. I know you don't.
So,
That's something you
so
can
this is
discuss.
really okay. So yeah, I'm pleased to talk about this. If you're okay with me talking about something that's fairly new, and with
New.
a big heavy disclaimer at the beginning, this is early research. We haven't even published it yet. It's just, I will say that there are 4 groups, 5 groups, including our own, around the world that have started targeting a new area of the brain called the precuneus. It's on the back of the head. One reason we love the precuneus is that it's the discomfort of TMS that you talked about before is almost zero back there because there's no muscles to contract. So when you do TMS, the muscles of the forehead contract and the muscles of the eyes contract, and that can be sore for some people. On the back of the head, there's no muscles, so it feels really common. The second thing we love about the precuneus is that the networks that it's engaging are always in the same place for everybody. So if you're ever trying to make sure you've got the coil in exactly the right place, some brain areas are quite variable from person to person. And so, this is why the idea in the SAINT protocol of doing an MRI came about. Like maybe we should do an MRI and just make sure we're exactly on the spot. Because if you're off the spot, it can either take longer, or if you're too far off the spot, it just won't work. But of course, one workaround for that is you just pick brain areas that are always in the same place for everybody, and then you don't need an MRI to get to. So the precuneus fits that bill. The precuneus also belongs to that transdiagnostic group of areas, which is involved across a wide variety of things. And so lately, and again, we have not published this yet, we have been starting to target these areas that are more consistent, like the precuneus. And here we are actually seeing people who get 3/4 of their improvement in the first week alone. And in fact, sometimes faster than that. And we have had cases of people walk in even halfway through the day and say, oh, I'm already starting to feel better. Or people who were really quite, chronically suicidal, who by the end of the day, for the first time in 20 years, are feeling a freedom from this and an actual interest in going outside and doing things. So you are in some cases now starting to see people who are getting better, within a day or 2 days, like very quickly. I don't want to claim that's everybody. It's hit or miss, but we never used to see that. So the idea of being able to do TMS, just do a day of TMS and have then that there's even a possibility that you might be better in a day or two, is exciting. As I say, it opens up the realm of possibility that we know that is feasibly possible during TMS. And now we can start to work on how to get that to be true for more people.
Amazing.
That's great. And Dr. Radowitz, you work extensively with ketamine and Spravato. You also have many of the patients here at Nushama who are on psychotropic medications. Tell me, if you can, how does TMS fit alongside ketamine, Spravato, or psych meds? Can you do them, in concert with each other? Should you take a multi-pronged approach to treat some of these hard to treat indications?
Right. Yeah. So, I mean, there's some research going on. There's some old retrospective studies showing some combined or additive effects of the two treatments being done in tandem or at some point, sometimes before and after. There's three ways of, I guess, approaching it. They could be done in parallel, so not necessarily on the same day, but they could be in sort of interweaving. What you can, it could be ketamine one day, TMS the second day, in some type of pattern like that. Then there could be, doing a whole protocol of ketamine first and then TMS, sort of exploiting that sort of neuroplastic window from ketamine and starting the TMS afterwards. And then there's doing TMS first and then ketamine for people who are non-responders. And, I guess this will have to be worked out with through research. But it could be very, very interesting for us. You think about it, it really depends also on the patient profile. If someone comes into us, highly, in a very acute state, acutely suicidal, or obviously safe enough, but acutely suicidal, we know our response rates with Spravato and IV ketamine are pretty quick. Sometimes after one treatment they leave and they're already, their suicidal ideations are significantly diminished or gone. So in cases like that, it would make sense to maybe start off with ketamine, and then for maybe to prolong the effects of the ketamine, it might make sense to go into a TMS protocol to help. So there is some overlap. They both work on sort of the same idea of this sort of rapidly open, like this sort of neuroplastic effects. And incredibly high response rates. So we're very excited to hopefully integrate these two programs well. And that'll have to be on a case-by-case basis to who would do best with which protocol and which combination of protocols. So.
Yeah, and we get the question a lot as we've started speaking to patients about this, what the cost is, especially considering that it's an off-label treatment for the one day. For the everyday kind of TMS protocol, many insurance plans will accept it, but it does kind of require the adherence to this kind of 36-day protocol, which is very, very difficult. I think for New Yorkers, where time is money, we're actually starting to offer this at just under $5,000 for a one-day treatment. There are other centers out there that are kind of offering this for much more expensive, and my guess is over time, the cost of it will certainly come down. Dr. Downar, one of the questions that I had for you as we were chatting a little earlier, and it was really interesting. A couple weeks ago, the President of the United States did an executive order about the kind of fast tracking of the approval, or at least of research monies going to certain psychedelics. And one of the big names, one of the big psychedelic molecules that came out of that executive order was ibogaine. And ibogaine is very, very well known to treat opiate addiction and alcohol addiction. And what most people probably don't know is ibogaine is actually a very brutal experience. It can be 14, 15, 20 hours in hell at times, although it does remake people's lives, and I know many, many people who've done very, very well. But Dr. Downar, one of the most interesting things that I've heard you speak about, at least touch on, is the fact that there is a circuit in the brain that TMS can also work on that has some similarities to what ibogaine can do. And I want to know if you can explain that to a layperson like myself and to everybody else on this webinar.
Sure, happy to do so. And again, please let's put this under a giant bold-faced capital letters disclaimer of very early, not even published yet, preprint research. But what I will say is that the same Stanford group that developed Saint also did a very influential study on ibogaine called Mystic, where one of the problems with ibogaine is it can be cardiotoxic for some people. So they protected the heart with magnesium, and then they gave the ibogaine. But to your point, people still undergo this extremely intense, up to 24-hour plus, psychedelic experience. It takes a lot of time to integrate afterwards. But the upside, 20 years ago, nobody would have thought that you could just reset opioid addiction with a 24-hour intervention, or you could reset 2 decades of PTSD or depression or anxiety, or that you could do this in veterans with severe brain injuries and concussions and so on. So the idea that that's even possible just shows what the brain is capable of under the right conditions. But it's not uncommon in medicine to find a treatment that does something miraculous, but it's kind of somewhat toxic. And then you then try and understand the basic mechanism and say, well, let's figure out what it's doing that's helpful. And maybe we can find a way to get rid of all the other things that are not helpful. So what was very important about the Stanford studies is they also collected brain imaging, and they also collected EEG recordings of the brain to see if they could figure out some changes in brain activity that were accompanying the improvement part. Look at who gets better and who doesn't, and then look at what changes are happening in the people who improve but fail to happen in the people who don't. So there's a preprint out from one of the groups at Stanford who analyzed this data, as well as they also looked at a second data set out of Europe that was independently acquired. And looking at the question of, well, what's going on in the brains of these folks when ibogaine is successful? I was somewhat curious about what the results of this would be, because when we spoke to when I've spoken to other clinics who have been experimenting with the precuneous treatment, as well as our own clinic, we just keep seeing the same profile. As people are saying that this sounds a lot like ibogaine. Like, yes, it's just TMS, and nobody's having hallucinations, but their PTSD symptoms are getting better, their anxiety symptoms are getting better, their depression symptoms are getting better. And I was saying to myself, I wonder if ibogaine could have something to do with the precuneous, because when we do precuneous TMS, it seems to be kind of, people describe very ibogaine-like stuff with it. So sure enough, the preprint out of Stanford, when they looked at the European patients as well as their own patients at Stanford, the areas of the brain that were showing the biggest changes in activity were right under the precuneous. And so again, it's a preprint. It's not even peer reviewed yet. It's all really, really, but to me, it opens up the possibility that TMS there might be a way of doing the one-day TMS in such a way that we can target the same circuits as ibogaine without having to put people through the ordeal or the danger of ibogaine, which would obviously be really, really nice. TMS is already FDA approved. Bear in mind, and I'll emphasize this again, when we're doing the one-day treatment is not just TMS. It's a combination of TMS with neuroplasticity enhancement. So, in those of us those people who work in the psychedelic space sometimes describe psychedelics as neuroplastogens. Like, they're not, the point is not that they cause a trip. The reason they're healing agents is because they engage the brain's neuroplasticity, and they allow us to rewire the circuits that are dysfunctional. So maybe we should call them neuroplastogens, because that's what they're really about. Well, D-cycloserine is definitely a neuroplastogen that, at least at these low doses, doesn't cause any sort of hallucinations or anything like that. And by itself, DCS doesn't do very much. But if you have TMS to tell it where to work, it's almost like the coil is delivering the pulses to tell it where to go to work. Then doing the precuneous treatment is essentially delivering pulses to the same circuit that ibogaine's working on, while giving a medication that just does the plasticity enhancement without all the other stuff. So it's interesting to see that. And again, this is something I'm hoping in a year or two we'll have better data on this and figure out. So I'll just phrase it in the form of a question. Is it possible that a TMS coil combined with D-cycloserine could engage neuroplasticity and do a lot of what ibogaine is doing, but in a more tolerable way that's sort of safer and uses stuff that's FDA approved now rather than many years from now? Oh, Jay, it looks like you might be muted.
Oh, there we go. It's a fascinating question, Dr. Downar, because I think a lot of people in the psychedelic community and people who've been in the ketamine space for a number of years, we also hear so much about ibogaine and its potential, but we also hear, wow, this is as much of a challenging experience both for the patient and the clinician surrounding the patients, and it involves a lot of monitoring as well as screening for cardiac issues. None of that would exist for a one-day protocol. And again, we're highlighting as you said, for everybody here, that this is early days in this. It's possible, and a lot more research has to go into it. You know, one final thing, I see Marissa has asked a question. Well, TMS is not a psychedelic. Are there other effects or experiences for people who undergo the treatment? So, you know, aside from the physiological, you know, maybe some slight muscle twitching in the face, maybe kind of some sign, soreness. Does anybody experience anything
Mm.
similar or any type of experience beyond the physiological?
So one way that this might be worth thinking about is what does TMS do in a person who isn't actually going through depression or anxiety? Because I mean, people have studied that for a long time. We know that there are circuits in the brain that are involved in things like impulse control and decision making and cognition. And you know, there are studies 15 years old or more in which they have had people come in and just do one session of TMS, and then they measure their decision making, and people actually get measurably better at impulse control for a little bit after they do, you know, one session of TMS to some of these same areas that we do. I've had people describe feeling cognitively sharper after doing TMS. And the other one that you commonly see is sleep. People who, if you tour around the world and talk to people who have ready access to TMS, by which I mean, you know, if you go into TMS clinics and you talk to the staff, what you find very quickly is that clinics that have been around for years, you'll often find the staff going in and just doing a session or two now and then when they're not feeling depressed. And if you ask them why they do it, a lot often they'll say things like, "Oh, my sleep becomes much better after I do this for a little bit." Now there are independent studies and randomized trials in the literature showing that TMS seems to be useful in insomnia. So far, no one's brought it to market through FDA, so it's not an FDA cleared indication. But I find it interesting that if you go to clinics where, you know, TMS is just lying around and anyone can pick it up and do it, that even if people aren't depressed, they do 2 or 3 sessions, they find they sleep better and they feel more emotionally even and better able to cope with things without feeling overwhelmed. So, you know, one wonders whether the wellness space will also end up including this because, you know, one of the effects that people describe you know, people do tend to describe things like even just a couple of sessions, people will describe better sleep and sometimes feeling a bit more focused and a bit better able to cope with things.
That's great. That's great. Well, um, Dr. Radowitz, Dr. Downer, thank you everybody for joining us. It's been fascinating for everybody to learn about this incredibly groundbreaking, revolutionary, I might add, new technology, new development within TMS. We're excited to offer it here at Nushama in partnership with the folks at AMPA. And we really, really look forward to seeing how this works in practice because it's one of the most exciting developments that I, as a entrepreneur in the space, and Dr. Radowitz, as a clinician in the space, have seen. So I thank you all for all your incredible questions, and we'll see you down the road. Take care. Thank you, everybody.
Thanks very much for the time.
Yeah,
It's
thank
been great
you.
chatting with you all.
Bye bye.
Thank you.